Good afternoon, good evening, good morning from where you're joining us from
It's
this.
good evening here.
Good evening, wonderful. It's also evening here in Kenya.
Oh, that's lovely.
Lovely, lovely to talk to you today. And to the rest of the people in the audience, I can see we have around 3 people. Just to check with you, Doctor, I think we should wait for around 3 minutes, 3 to 5 minutes for people to join in. I don't know if that's okay with you.
That's perfectly fine with me.
Yes, so let's just wait for 3 to 5 minutes for people to continue streaming in, and then we will begin promptly at in 5 minutes.
Sure.
Lovely. I see people are streaming in, and I think we'll just proceed. We were just waiting for a few more people to join us in this incredible call today. And I see that we have a good number and we can start. My name is Grace Nekesa Waswa. I am the moderator of today's conversation with the lovely Dr. Priya, who is going to be our presenter and our guest today, talking to us about tackling infertility and a walk through the Ivf Lab. Just a few ground rules so that we can be able to understand one another as we proceed. Please mute yourself if you are not speaking. If you have a question, be sure to put it in the chat. Be able to address that as we proceed. If you have a comment or a concern, please put that in the chat box, or you can raise your hand. I believe Google Meet provides those features where you can be able to raise your hand just in case you have a question or you have not understood anything. Dr. Priya, welcome to today's conversation. I am looking forward to learning a lot. My background is in law, so I'm always looking forward to learn everything and anything that I need, because in the law practice, we also need medicine to do a lot of things. So I'm just going to turn my video off so that I can read your bio, and then we will go directly to handing over the presentation to you. So just bear with me as I turn my video off for 1 second as I read the bio.
Sure. Absolutely.
Right. But even as we're getting ready, please let us know where you're joining us from. I understand that we're having different people from different continents. Myself, I'm joining from Kenya in Africa. If you're joining from any other part of Africa, please let us know. It will be very lovely to know where you're joining us from today in this conversation. And as you do that, I am going to read the doctor's bio, an incredible lady who has done a lot of things, and I'm sure you're looking forward to hearing the work that she has done. So Dr. Priya, and I'm sorry if I missed the pronunciation. I will try to make sure that I pronounce the names as correctly as possible.
You're perfect. Dr. Priya.
All right. Thank you. Dr. Priya, after her completion of the MBBS in India, just a minute. Okay, I think I'm having issues with people joining in because I'm having to admit people as I read. So 1 minute. So sorry about that. 1 minute as I sort that out. All right, there we go. Dr. Priya, after her completion of the MBBS in India, was trained. Okay, I don't know if I'm having trouble when I try to read the bio. I need to admit somebody else. Or should we proceed? I think what we can do, Doctor, is just to have you proceed by introducing yourself. Just do introduce yourself, because there's going to be a lot of interruptions as I try to admit people in. So let me hand it over to you, and then I will go directly to the questions after you have introduced yourself.
Sure, I shall. Okay. I'm Dr. Priya Kannan, and I completed my basic undergrad medical degree here in Chennai, here in Tamil Nadu. After which I went to University of Sydney in Sydney to do Masters of Medicine in Reproductive Health and Human Genetics. And then after completion of that, I shifted to Monash University in Melbourne to do Masters in Clinical Embryology. After that, I came back to India and started working as embryologist and a fertility specialist in the clinic at Garbba Rakshambigai Fertility Center. Presently, I'm one of the directors of the center, and I am the Ivf Lab director as well. We have two centers, one in Trichy and in Chennai. And I also have extensive academic involvement in the fertility fraternity in our country of India. I have served as the past president of Academy of Clinical Embryologists of India. Apart from that, I'm also on the management committee of other national fertility societies, such as the Indian Society of Assisted Reproduction, and I'm presently the joint secretary of the Indian Fertility Society as well, of the Tamil Nadu chapter. So that is a very small intro about me. But apart from fertility, my another huge interest is reproductive genetics, which is another arm of fertility that I learned in depth in University of Sydney. So genetic counseling is another aspect of mine, apart from all the fertility speciality that I do. Going on to the talk of the day, I wanted to come back and say, what do we do now? Like, do I have to start with the basics? But then I said, no, everybody must have heard about the basics. So I'm going to give a little bit tidbit about the advances or the latest innovations that is actually helping us on a day-to-day basis, and also reduce the burden on the patient and move on to give the more important and the more let us say, in the interesting part of what actually goes on in the Ivf lab. So we all have heard about laparoscopy. Fibroid is a very common, I've heard that the incidence of fibroid is quite high in the continent of Africa. And laparoscopy is one armamentarium which has been with us for decades to help us in that without the removal of the uterus. But however, before going that, we used to have a lot of difficulty in mapping the laparoscopy. And with the advent of CT and MRI, we used to use the CT and MRI to map the fibroids before laparoscopy. Why do we have to map the fibroids is because once we map the fibroids, and it's very easy for us on the laparoscopy table to go ahead and remove the fibroids. So the mapping of the fibroids is a key to a very successful laparoscopic myomectomy. But now we have the 3D and 4D ultrasound. Here you see the picture of a normal endometrium there. Here also a normal endometrium. Here you can see a subseptate endometrium in the bottom left picture. And the bottom right picture, you can see a complete septate uterus. Are you able to see the flow of the slides?
Yes, we are able to see the slides on my side. I believe everybody is able to see that as well.
Absolutely. That's great. That's great to hear. Here in this picture, you will be able to see a picture of the fibroid pushing, or it's indentating the endometrium. So this way, this is a submucous fibroid, which obviously has to be removed. But even if an intramural fibroid, that is a fibroid in the musculature of the uterus, if it is pushes on the endometrium, also we would be able to see by this 3D and 4D ultrasound, we have been able to map the fibroids with the uterus perfectly fine for the surgeon to take care of it. And in case of
allow me to for a minute, please. Sorry about that. I've just realized the slides are not moving. I don't know what happened. Yeah.
Are you able to see the slides moving now?
Yes.
Okay, then I'll keep it in this this mode itself. Yeah. So here you can see the fibroid in the uterus, which is indentating into the endometrium, and hence this is a submucous fibroid, which can be beautifully removed using a hysteroscope and a laparoscope. just like this. We'll be mapping the fibroid either on the fundus or on the sides or wherever it is, or multiple fibroids as well can be beautifully mapped for the surgeon to do a perfect picture of it. This is a picture of a hydrosalpinx. Hydrosalpinx is nothing but infected fallopian tube with a collection of fluid in it. We can do a tomographic ultrasound as well. There we can move through the hydrosalpinx just like how you do in a CT. The same can be applied for endometriosis as well. Here you can see a beautiful picture of a stimulated ovary, and this is one of the picture where we call the automated follicular assessment. Once I do a rendering of this ovary, and you can see the follicles in 3D with the volume, and it looks absolutely amazing when we have lots of follicles. And when you get confused about the planar on the number of follicles, this gives on the list of exactly the, for example, on the left hand side you will see a green dot. The number, the row will be in this green, telling us what is the size of the follicle and what is the volume of the follicle. So it is beautifully demarcated in this. Of course, the 3D and 4D ultrasound has given us the power Doppler to look at the vascularity of the uterus and the endometrium, helping us decide on which would be a perfect endometrium for frozen embryo transfers. The next one that we've had in the recent times, I won't say it's very recent, it's been around for about 10, 11 years, is the anti-Mullerian assessment of the IMH, that is the anti-Mullerian hormone, which is a extremely sensitive marker of the ovarian reserve, but of course it is a poor marker of gonadotrophin response to gonadotrophin stimulation. Now, moving on to the introduction of an IVF lab. Since I work in the IVF lab, and we know that we don't allow people much into the IVF lab due to avoid contamination and to preserve the air quality in the IVF lab. The more the people, the poorer the air quality will be, and hence we don't allow too many people. And hence, to give you a sneak peek into the IVF lab, that is something always anybody is interested in. Let me share with you when we started. Our modest beginnings was with the birth of Louis Brown on 25th July 1978. And we've had about 4 to 5 million babies being born through IVF or any other assisted reproductive techniques so far. And in some countries, the babies born through ART constitute about 2 to 3% of the total babies born. But what do we have as advanced technology? We have a moral imperative to make assisted reproduction more effective. Right now, we have about 40 to 50% live birth rate. So we must always strive to make it more effective, less burdensome for the woman involved. We give a lot of injections, and also it is not very financially affordable for many. And hence, we must make it more affordable and less burdensome for the woman involved. Make it more widely accessible. It is not accessible everywhere. It is a niche technology available only in certain centers, and it could be available in smaller centers as well. That the quality control and the quality assessment makes a huge difference, and hence accessible. Making it more accessible does not mean lowering the quality. We have to make the same uniform quality to be accessible for everyone around the world. So what is ART involved? It facilitates the sperm-egg interaction and hence improves the likelihood of fertilization and pregnancy in infertile couple. So what are all there? The basic ones are the IUI, the Ivf Sa with the embryo transfer. The allied technology for that would be the semen cryopreservation and the embryo cryopreservation. So this is just give you an example of the difference between a natural cycle and an IVF cycle. In a natural cycle, you would have only one mature egg coming out, growing and ovulating as well, which if we use an IVF, the success rate will be extremely low. But to make a note of it, to help you with the idea, the first baby, that is a Louis Brown, was conceived using natural cycle. But then they tried many times. But then now the woman undergoes Ivf stimulation, which means we give hormonal injections where the woman is able to ovulate with multiple mature eggs. for which she has to take gonadotrophins and then antagonist. Using the most commonly used protocol now is the ANTAC protocol. Hence, this is a pictorial depiction of the antagonist protocol. So what we do is, from the cycle, from day 1 or day 2 of the cycle, the gonadotrophin is given. And once the follicle reaches about 14 millimeters, we start the antagonist, and it's continued through until the follicle reaches about 18-19 mm, when it is termed a dominant follicle and ready for the HCG injection to trigger the ovulation. A smaller version of this is used to prepare the ovary for an IUI process. So what does IUI actually involve is we prepare the oocyte, have 1 or 2 oocytes more than the natural cycle. I'm sorry that there is some background noise throughout that, because there is a heaty elections going on in our city, the local elections, and it's everywhere. I'm not able to escape that from any part of the hospital that I work from. So please pardon me if you hear that. So in IUI, what we actually do is we prepare the semen sample and separate the extremely motile sperms. So the extremely progressive motile sperms are separated, and we concentrate them in 0.2 to 0.3 ml of the culture media, and that 0.2 to 0.3 ml of the culture media is placed inside the uterus. So, and hence the extremely motile sperms pass through the fallopian tube and reach the oocyte when it is ovulated. What we do here is actually give an edge over the natural cycle by selecting the extremely actively progressive motile sperm and decreasing the distance of the sperm which is has to travel. In a natural cycle, the sperms will be deposited in the vagina. Here it is deposited right near the fundus of the uterus, and hence that 15 to 20 or 10 to 15 centimeter is cut down for the sperms. And here you can see a Maker's chamber, and that is how we do the semen analysis. So you can see some sperms here. So we analyze, or we measure 10 squares of this, and the number of sperms found there is the concentration, and the percentage of the sperms that are motile. For example, if I count 100 sperms in these 10 squares, then it's 100 million concentration, of which if I see like only 10 moving, then it's only 10% motility in that particular sample. So as I told you, what we do is it goes through the semen sample, goes through a preparation, and we separate the extremely actively motile sperms. And then it is placed right at the fundus of the uterus. So the next step is to go for IVF, and then after that would be the ICSI. So what does an IVF actually involve is the woman has to undergo the injections. That is the first step. Then she has to undergo the egg pickup, and then the insemination, which means the IVF or injection. Insemination or IVF is the conventional IVF. Injection means always the intracytoplasmic sperm injection. Then we check for fertilization of the oocyte with that particular sperm, culture those embryos to 3 days to maximum of 5 to 7 days, and then pick or select the embryos for transfer, select based on the morphology and sequential morphological assessment to select the embryos which has got the maximum potential for implantation. Day 0 is the day on which the egg pickup happens. So what we do is it is vaginally done. So the vaginal probe is used. It goes through, and then we insert a needle. There is a guide and through which we insert a needle, and the needle goes into each of the follicle, and we aspirate each of the follicle, and the follicular fluid is given to the lab to check for any oocytes. And that is how you would see the oocyte cumulus complex under the microscope, under the stereozoom microscope. And when the same is spread nicely on the base of the dish, and this is how we grade the oocytes. When we want to do an IVF, that is the conventional IVF, it is not much fanfare. What we do is we do the cumulus oocyte, we identify them, and then each one of it goes into each of one of these drops, and surrounding each drop you would put sperms at the concentration of 100,000 sperms per ml. So that's about it. And then it goes back into the incubator, and it is not disturbed until the next day when we have to do the FERT check. Why? And when do we do an IVF? The more conventional IVF is done when there is a blocked fallopian tubes, and the sperm count here has to be good. An IVF cannot happen when the sperm count is not near normal or above normal. When the patient has to undergo ICSI, that is intracytoplasmic sperm injection, the same eggs has to be denuded. That means all the oocyte and cumulus cells have to be removed. The coronal cells also have to be removed, and then you get to see the eggs like this. So here you see the egg surrounded by the zona pellucida. Here you can see various types of egg, the eggs with small vacuoles, here with large vacuoles, here with the sperm, another abnormality called the smooth endoplasmic reticulum. Here you can see the egg with a dark cluster or a refractile body. So you will be able to see the morphology of the egg only after denudation of the egg. And here you can see the ICSI. I actually have videos of this. I will show after the presentation for just to maintain the continuity. What we do in ICSI is that this is the setup of the ICSI. What we do is we immobilize the sperm by crushing the tail of the sperm to the bottom of the dish, and then we inject the sperm right into the egg. That is called the intracytoplasmic sperm injection. Where is it used? It is the only technology that can be used when there is a poor sperm count or very poor sperm motility. When we are using testicular sperms, when the sperms are not available in the semen sample, we can go ahead and retrieve sperms from the testis. And when we are using the testicular sperm, ICSI is the only procedure that can be done. Conventional IVF cannot be done, because if you use that, then there will be an absolute fertilization failure. When there is an advanced mental age, 37 and above, we prefer to use ICSI. And when there are very less number of eggs, such as 2 eggs or 1 egg or 3 eggs, we prefer to go in for ICSI. So on the day 0, the egg pickup is done, and the egg undergoes either insemination or ICSI based on various other factors. And then the embryos or the injected or the inseminated oocytes are kept inside the incubator. The next day, they are taken out and checked to see whether the egg has fertilized. If the egg has fertilized, you would see 2 pronuclei like this, and that means it has fertilized. If you have more than 2 pronuclei, it is an abnormal fertilization, and that embryo is not used. After that, you can check the embryos on day 2, day 3, day 4, day 5 to see the progression of the embryos like this: 2 cell, 4 cell, 5 cell, 6, 8, and 10 cells. A 2-cell embryo is found at about 25 hours after the insemination or ICSI. It is one of the very important prognostic markers, and if the embryo has cleaved to 2-cell by 25 hours, that means its implantation rate will be quite high. On day 2, when we check the embryos, we expect that it should be about 4 cells. On day 3, it should be about 6 to 8 cells. And then again, here the day 3 embryos, another of the day 3 embryo. This is also another of the day 3 embryo, which has started compacting, which means it has started to lose some of its borders and start to merge with one another, which means it has started going into the next stage of the development. On day 4, you can see here more than 8 cells, which is starting to lose the cell borders and coming together. On the right, you can see a completely formed morula, which means here you will not be able to appreciate any of the cell borders. That's another picture of a morula. And that is a blastocyst, which means that is what we see, the embryo, which we expect to see on day 5 of the cell. And it can either occur on day 5 or day 6 or day 7. We would wait until day 7 culture to see if the embryo goes into a blastocyst. We are happy to see it even on day 6 or day 7, and they can still be used. A blastocyst would have 3 structures. One is the inner cell mass, which would form the baby, and then the trophectoderm, which would form the placenta, and the blastocoele. Another picture of a blastocyst. More pictures of a blastocyst. This is an early blastocyst. This is an expanded, this is a full blastocyst. This is an expanded blastocyst. How do we differentiate between a full blastocyst and expanded blastocyst? In an expanded blastocyst, there will be thinning of the zona pellucida, and that's how we know. And this on the bottom is the hatching blastocyst, which means the blastocyst is coming out of the zona pellucida, and that is when it goes ahead and forms, it starts to implant in the uterus. And here in the bottom right, you can see a completely hatched blastocyst, which means it's completely out of its protective shell of the zona pellucida. More embryos, and that's how, when you have such beautiful embryos, you need to be able to select. And there are basically many criteria based on which there is selection. The most important and the most widely used is the sequential morphological selection of embryos. So we would start applying the grading of the embryos right from the 2-cell stage to actually from the oocyte as well, from the egg to the 2-cell stage to the pronuclei to day 3. We don't usually check on day 2. We go from first check straight to day 3, and then to day 5. So we would be marking each of the embryo based on this, and then we would be selecting the embryos. So as of now, it is only the morphology. Yes, there is embryoscope and time-lapse imaging giving us morphokinetics, but since the algorithms are not set as of now, we still rely more on the morphology right now. There are more advances coming in, such as embryoscope, that is the time-lapse imaging being combined with artificial intelligence, and we are hoping that all of this put together would help us select the embryo with the maximum implantation potential. So what do we do after we select the embryos? What we do is we do the embryo transfer. That means through a catheter, it goes inside and it's placed about 1 centimeter to 1.5 centimeter below the fundus. The maximum number of embryos we would transfer is 2 embryos if it is a day 3 embryo, and 1 expanded blastocyst if it's a day 5 embryo. So what do we do with the rest of the embryos? They can be happily frozen. So what are all the specimens that we do cryopreserve for future use? It starts from sperms to oocytes, embryos in all stages. Pronuclei, cleavage, blastocysts, hatched blastocysts, expanded blastocysts, everything can be frozen with utmost efficacy. Testicular tissue, even ovarian tissue can be frozen. Though ovarian tissue is still experimental, all the other are clinical procedures, established clinical procedures that can be done in all IVF centers. So semen cryo was the first we started doing, and that was way back in 1950s. And then came the embryo and the oocyte freezing. The embryo and oocyte freezing, it is not just useful when we have supernumerary embryos, but it's also used when we want to segment the cycle. That is, when somebody is giving lots of eggs, such as a PCO, and to avoid OHSs, when we don't want to do a fresh transfer, we would freeze all the embryos and go ahead for transfer after 2 cycles to avoid an OHSs. Every clinic is expected to be OHSs free presently, and hence this vitrification and the segmentation of the IVF cycles has greatly contributed for us to have OHSs free clinic. In our center, we haven't had an OHSs maybe in the past 7 to 8 years, and basically because of the segmentation, cycle segmentation, and the effective vitrification of embryos which we've been having. Oocyte vitrification is another beautiful option that women do have right now. Either when they have been diagnosed with cancer, they can go ahead and freeze their embryos, their oocytes, or when they want to go ahead and do social freezing, which means that they want to freeze when they are in their 20s, while they want to take care of their career and come back and use their oocytes later on at their reproductive career. Many babies have been born with oocyte vitrification right now. It is almost it's a clinically accepted routine procedure in IVF labs right now. So there are some few advanced techniques that are in common usage now. One is assisted hatching, which means presently we use only laser hatching. We don't do either the chemical or the mechanical hatching. So we would point the laser and then shoot the laser shots here, and then you can see the hole in the zona there. And one of the most important, assisted hatching has got very limited use in terms of other things, but the only objective use of assisted hatching or to breaking of the zona is when we want to do a biopsy of the embryo. We can do either a blastomia biopsy, which is on day 3, or day 5 biopsy, which is on day 5. And what do we do with the pre-implantation? What do we do with the biopsies? What we do is, it is called the PGT, that is pre-implantation genetic testing. We can test for the aneuploidy screening, that is to know if there is any chromosomal problem, number of the chromosomal problems in the embryo, or you can test for any translocations, inversions, or anything using a SR, that is structural rearrangements, or monogenic disorder. Suppose a family has got a monogenic disorder, single gene disorder running in their family, that also can be tested from the embryos to prevent passing on of that single gene disorders in the ensuing generations. So now, while we had only 4 lines to start with, now we have the plethora of assisted reproductive technology has improved or has expanded from just IUI, Ivf Sa, semen and embryo cryopreservation, to oocyte cryopreservation, ovarian tissue cryopreservation, to pre-implantation genetic diagnosis, which encompasses the SR and the monogenic diseases, or pre-implantation genetic screening, which is an aneuploidy screening, that is PGT-A. So, and there are other allied procedures such as blastocyst culture, to assisted hatching, to pole scope, where we can see the spindle in the oocyte, IMSI, where we can see the sperms at 6,000 magnification. Metabolomics have been tried to select the best, the embryo which has got the maximum implantation potential. And of course, there is a time-lapse imaging, and so many more and so many others keep coming. But as of now, yes, blastocyst has again become one of the most standard culture systems in the laboratory. Cryopreservation is again routine in any IVF lab, but assisted hatching or PGT they're all yet to be established. They are established, but then their use or the benefit to the patient is not yet established. So they are still under to be analyzed. And of course, success rate and everything, I'm just going to jump. This was a presentation that I did I included for the Indian audience, where, yes, actually after Louis Brown, we had 1 baby in India in just 67 days later. But of course, it was not acknowledged, and the poor doctor had to, he was so harassed that he committed suicide. So I'm just going to slip a few slides and just show you the picture of the baby. She's Durga, or Kanupriya, the first IVF baby of India. And so, while we do such high technology, what is important to the patient, it is not just the pregnancy rate. The safety and ethics matters predominantly in any IVF. So in India, we do have the ICMR guidelines. Presently, we have the ART bill, which has come into vogue, and it has been since Jan 25th of this year. And we've always followed the European, that is the ESHRE guidelines on the best practices in an IVF lab. Any IVF and its result is a tribute to the mothers, because for whatever reason, even if it is the azoospermia or any other reason, the lady chooses to undergo so much of injections and procedures and everything to attain motherhood. It is always a tribute to the mothers. And that is just a joke, whether we are going to have menopausal, premenopausal, and actual or to-be menopause pregnant women. But right now in India, we have had a clear restriction on the age limit for doing ART in our country. And that is just a picture of a collage of many of my IVF babies who just visited me in the past 1 month. It was just a simple joy to meet them, because I look forward to all the school holidays nowadays, because I seem to be meeting either one of my babies during that time. So yeah, so many, and all these patients actually came in for their second baby from the embryos I've already stored for them. So it is always a pleasure to meet my patients, and more so a pleasure to it's enthralling to meet my babies whom I saw as 1 cell, then 4 cell and 8 cell. To see them this big and hugging me is always, let me say, it's the pleasure of the job. The rest of it doesn't matter. This is what we look forward to. And always we have to understand or believe that it's just your embryos or the oocytes has to be in safe hands, and that's the priority we give for everyone. And that is why ethics and safety is the priority in any IVF lab. Thank you so much for the patient listening.
Amazing. Thank you so much, Dr. Priya. That has been such an informative session, and we've actually learned a lot. And as you've said, it's always a joy and a pleasure for you to meet these children, these babies that you saw from 1 cell to 2 cells to 4 cells. I mean, that's really, really, really impressive, and I'm sure you feel with so much joy once you meet these children. Now, we do have a few questions that was shared. And the members of the ones who organized this wanted to have you address this question. So I'm going to read 2 questions, and then you'll address them, and then I go to 2 questions, you address them until we finish the questions, because I see we have 18 minutes. Yeah. And the very first question was, how do you improve success rate of IVF in IVF? That's the first question. And the second question is laparoscopy a must for all prior IVF? So the first question, just to repeat, is how to improve the success rate for IVF, and is laparoscopy a must for all prior to IVF? Over to you.
Thank you. Thank you for those questions. How do we improve the success in IVF? Is the success of an IVF is dependent on the age of the female partner. So the earlier the IVF is done, the better is the success rate. So that is the crux of that. Number 2 is to select or to go to a clinic that has got the maximum. It's a clinical side, and the embryology side has to go together to give you the maximum benefit. Number 3 is to make a diagnosis and treat the diagnosis as much as possible prior to going for IVF. There is no point in jumping into IVF. Okay, you see that there is some problem, and then straight going to technology may not give you the best success rate. However, diagnose why the person or the couple is infertile, and then treat that diagnosis as much as possible. For example, endometriosis, treat the endometriosis prior to taking them for IVF. If it's a fibroid, if it is a small fibroid somewhere in the uterus, doesn't matter. But if it is a big fibroid, that is more than 3 or 4 centimeter, it can affect the pregnancy rate. So it's best to do the myomectomy and then go for IVF. So certain things like this we must address prior to going to IVF. And number 3, get into a better general health, which also matters when we going for IVF. So general health does not mean only the female partner. It also means the male partner, because they contribute 50% of the genetic material as well. So these are the 4 major things that would contribute to the success of to increase the success of an IVF procedure. In terms to laparoscopy, there used to be a time when we used to do laparoscopy for everyone prior to IVF. Right now, it is not mandatory. Even the evidence to show that whether hysteroscopy is mandatory or is it needed for, or does it help in improving the success rate in couples going through IVF, the evidence is very weak. So it is not mandatory for everyone to go through laparoscopy or hysteroscopy prior to going in for IVF. Only if there is a problem such as fibroids or endometriosis, then you need to go for a laparoscopy, hysteroscopy. Even then, I've had many a couple where I could treat them medically for fibroid, shrink the size of the fibroid, such as is about 1 centimeter away from the endometrium, do the embryo transfer, and they go ahead and get pregnant. And after the delivery, we go ahead and do the myomectomy. It has also happened in some of the couples. So it varies from one patient to another, but yes, it is not mandatory.
All right. Thank you so much for that. And just to highlight a few things that you have mentioned, just for the purpose of mental revision for those that are with us here, you've said that for us to improve the success of the rate of IVF is dependent on the age and then the maximum experience of the facility you're going to be using. You've mentioned factors such as the general well-being and health, which is actually connected to some of the questions that I have been given here today. And just to connect with that, to that point, one of the questions that I was also given was, what is the ideal lifestyle? What is the ideal food to improve IVF? And I also want to connect that to another question, to another point that you stated, which is endometriosis. So after you've addressed the question on ideal food and lifestyle and to improve IVF, maybe you can touch on the severity of endometriosis and how does that correlate to fertility, the severity of endometriosis, and how does that correlate to fertility?
Sure. So addressing the first question on what is the ideal lifestyle or food, it has been known, it has been established since 1990 that once there is a reduction of 10 to 15% of the BMI of the weight in the female partner, the quality of the egg improves. So how do we reduce the weight? That's the more. You always know that to reduce weight, to control on your diet is 80% and the exercise is only 20%. So the food is the major part. We advise all our patients to go through a less carbohydrate diet, increase their proteins. We supplement and have more vegetables and fruits, reduce red meat, have at least 2 liters of water a day, have daily at least half an hour to 1 hour of walking or some exercise form. These are all the important things and have at least 6 hours of sleep. So apart from these lifestyle, we also supplement them with some vitamins and B complex and everything, just to make sure this from this previous cycle itself, we start all that stuff to make sure that the couples for a betterment of the success rates. Having said that, there are people who go to the gym, strenuous exercise at the gym. That is perfectly fine with us, no problem. But one thing we don't advise is to take the supplements given at the gym, because it does have some amount of, we prefer to give them the pharmacological grade whey protein and not the one that is given in the gym. That's something we always tell them. So after that is the question on the endometriosis. So a healthy lifestyle is what we need prior to IVF. And I think the healthy lifestyle is uniform around the world, to have a less carbohydrate diet, high protein diet with a lot of vegetables and fruits, lots of water, daily exercise. I think that's that simple and all around the world. And in regard to endometriosis, yes, what we expect is that the more severe the endometriosis, the more severe the fertility problem would be. But somehow that is not correlated directly in all patients. Some patients with grade 4 endometriosis on laparoscopy have gone ahead and had spontaneous conceptions, whereas some people with minimal endometriosis have gone ahead and had only IVF for conception. So it is something, an enigma of a sort. But what is important is when somebody undergoes a laparoscopy for IVF or for endometriosis, it doesn't stop there. You have to be on treatment for the next 3 to 6 months continuously to suppress that endometriosis and continue for the next 1 year or so to have the effect of the laparoscopy in you, which means the laparoscopy has improved the internal milieu in the peritoneum, that is in the abdomen, for a better implantation and pregnancy rate. Make use of that. Just don't stop the treatment. Continue the treatment and try to get pregnant within the next year, which means that then you will have a high chance of having spontaneous pregnancies, even spontaneous pregnancies to the tune of 30 to 40%.
Yeah, amazing. And I guess with your vast experience in this area, your advice is really sound, and I believe that our audience is actually paying attention to that. Now, on to the next question. But before I go to that, I just want to also highlight a few things that you have mentioned. You've talked about in terms of ideal food and lifestyle that we're supposed to live to improve IVF. You talked about reducing the weight. You've talked about less carbohydrates, more proteins, less red meat. You've talked about exercising. And one thing that I've gotten from that, you've said that you always advise your patients not to take the supplements from the gym, and they are supposed to take supplements that come from the hospital, and then at least 6 hours of sleep. Just to proceed to the next question as well, Doctor. there was a question on fibroids, yeah? And this question is that should all fibroids be removed? Should all fibroids be, is it necessary to have all fibroids removed? And another question that is also related to fibroids, does fibroids interfere with fertility?
Okay, so first let us address the question on does fibroid interfere with fertility? From there, we will know the answer to the next one as well. Fibroids do interfere with fertility if they are above a certain size. So for example, if they are above 4 centimeters, even if they are away from the endometrium, it has been shown that by evidence that they can affect the implantation because of the muscular movements that it can cause. So any fibroid which is more than 4 centimeter, we advise that we remove the fibroid prior to going for an embryo transfer. This is if the fibroid is away from the endometrium, which we call as intramural or a subserous. A subserous fibroid does not need to be removed unless otherwise it is exerting any pressure symptoms on the bladder or the rectum or on the ureter or anything like that. But if it's an intramural, if it is more than 3 to 4 centimeters, it's best removed. In terms of the fibroid, which are very close to the endometrium, or the ones just like I showed with the indenting into the endometrium, we call them the submucous fibroid. A submucous fibroid, which is very close to the endometrium, if we can treat that medically, and usually submucous fibroid will not be too big like that of an intramural. It could be about 2 or maximum 3 or even less than that. In that case, if we can remove the ones which are very close to endometrium, sometimes, yes, it is best to remove. But then if we can at least try a trial of medical management and then reduce the fibroid and then go ahead and do the embryo transfer, that also can be done. But for the fibroids which are inside the endometrium, that is completely submucous, they necessarily have to be removed. So how fertility, fibroid affects fertility or whether it has to be removed is hugely dependent on A, the size, and B, the position of the fibroid.
All right, dependent on the size and the position of the fibroid. All right, one final question, which I believe you had tackled a bit in the first question that I asked on how to improve the success rate of IVF, is how to select a clinic for IVF. You talked about maximum experience in the facility, and maybe you can broaden that and just talk about that broadly.
Okay.
Yeah.
So there are, how do you choose an IVF clinic? RIM is the experience that they've had for years of experience. Their success stories, like, success rate. But the success rate sometimes may not be the right way. For example, in our center, we don't do much of our patients want only their own eggs. So even if the patient is 40 or 42 years or 44 years old and they wish to use their own egg, I would still give them a try. I would say, I would help you do that. So let's go ahead and do that. They may have 3-4 stimulation before they give me 1 egg also. So at the end, we've had 4 stimulations, 1 egg, and hence the result may not adequately reflect. But then you will have to go into the subheadings and then see what is the type of patient they are looking at. That is something your referral doctor would be able to look at. So number 1 is the experience. Number 2 is always look at the team. An IVF clinic must have a clinician, an experienced clinician who has been trained in infertility. Number 2, an embryologist, an in-house embryologist who is there to maintain the IVF lab and to do the procedures. The IVF lab is the heart of an IVF program. The better you maintain it, that means do the quality control on a daily basis and the quality assurance on a regular basis, the quality of the IVF lab is maintained. And the embryos and the pregnancy rates are absolutely dependent on it. A good embryo is the key to many endometrial reactions. So, and hence some you must choose. Number 3 is something which has got other facilities as well. Do they have a good scan? Do they have the assisted hatching? Are they able to do PGT? And these are all the techniques that have been sort of better proven than the other allied techniques. So if they are there, then it's a good clinic for you to choose from. So it is the facility of the experience, the facility, and the personnel. All these three factors have to be looked into prior to selecting any IVF clinic.
Amazing, amazing, amazing. And I love how you have clearly elaborated what is required, what is needed in selecting an IVF clinic. We have come to the end of our discussion today, and it has been such an informative session. We have truly learned, and I know from our audience that they have learned. We have maintained a kind of consistent audience, meaning they enjoyed the conversation today. And so since we have around 4 minutes, I'm going to hand over to you, Priya, to maybe say a parting shot, something that you'd like to say to our audience today. Any parting shot, and then we can finalize today's conversation.
Yeah, thank you so much for all the compliments. It's been amazingly wonderful for me as well to be addressing this wonderful gathering. And what I wish to say is, like, when patients come, they fear IVF. That is the basic thing that everybody goes through. They fear the process of IVF. But something that I wish to say, that we have made IVF as simple as possible for the patients. And that is probably why, and make it as comfortable for them. Like, it's the ease at which they can come into the clinic and go that makes them comfortable to go through the procedure. So in that case, it is something that I have strived to make it as individualized to each patient as possible, and to make each patient's, every visit to the hospital they must be looking forward to it. They shouldn't be scared of going into the hospital. That's something, because this is not a procedure that is life-saving, it is life-giving, and hence they should be happy about it. So that is something we strive to do it at every visit for our patient. And that is why our patients come back to us for their second or third child or whichever. So you must put them at ease. They shouldn't have the fear. And that's another thing that most patients fear after IVF is, do I have to be on bed rest? Sorry, I forgot to mention it about the entire conversation. The bed rest or the bedridden thing is something we don't advise, because it is not shown to have any effect or any improvement in pregnancy rates. My patients after embryo transfer go back to work, especially doctors. I tell them, please go back to your routine work. So they go back and still they conceive. So it's not that you have to be tied to your bed to get a higher pregnancy rate. So that's something. So the fear of getting the injections or to be bedridden after the procedure need not be there in any patient. You must give that assurance to your patients prior to going for their IVF.
All right. Thank you so much, Doctor. We have 1 minute to end the call, and this has been such an informative session. As I've said, I've enjoyed having this conversation with you, and I am sure that all of us have learned something too. And I love it, the way you put everyone at ease with the conversation, and even with what you do, with the work that you do. I believe that's something that's needed in the medical profession, and you embody that. So that has been such a great time talking to you. To everyone, this has been such a great time. I cannot see any comments or any questions. I have addressed all questions, so I'm going to have to end the call right now. Thank you so much for everyone that has joined us, and I hope that we can be able to meet once again and have a discussion on any medical conversation that we would want to have. All right, you can leave the call now. Have a great evening.
Thank you very much for this, and I absolutely enjoyed it. Thank you.
All right, bye-bye.
Thank you.